Okay, so the next topic is myasthenia gravis. So this is a chronic autoimmune condition, which is more of a disorder of neuromuscular transmission. When the body produces autoantibodies that attacks the neuromuscular junction, usually the acetylcholine receptors. The peak incidence age is the third to the fourth decade in women, and sixth to seventh in men. And the main clinical features that occur in myasthenia gravis is fluctuating muscle weakness. So the muscle weakness worsens with activity and improves with rest. So as the day goes on, the muscle weakness worsens and improves once the patient rests. The affectation of the muscles of it could affect different parts of muscles of the body, such as in the eyes, there could be ptosis, there could be diplopia, could affect swallowing, chewing, could affect speech, could also affect respiratory muscle, which tends to make it like an emergency. It's a condition we call myasthenia crisis that will require ventilator support because the patient is unable to breathe using his own respiratory muscles. It could also affect the limbs, causing limb weakness, in which is worse in the evening, basically. So the diagnosis is majorly based on clinical history and also examination, but we tend to do blood tests just to confirm the suspicions of myasthenia gravis, and the test that is done is the serum acetylcholine receptor antibody. That's the first line. But there are people that will test negative for this test, and if there is still high suspicion of having myasthenia gravis, the other test that can be done is the muscle specific thyroxine kinase receptor. So this occurs is positive in a rare type of patients with myasthenia gravis that the antibodies attack the thyroxine kinase receptor as against the acetylcholine receptor. Then also some other investigations that should be done ideally in patients with myasthenia gravis is thyroid function test. Also the thymus to do a CT and MRI. Most up to 50% of patients with myasthenia gravis tends to have some problem with the thymus gland, thymoma basically. It could be thymoma, benign swelling, or it could even be malignant swelling of the thymus. And most people with thymoma also tend to have myasthenia gravis, so it's either of both ways. Tensilon test is a test that is rarely done now, but if there is diagnostic doubt about patients having myasthenia gravis, then this is something that can be done. But because of the high risk of causing bradycardia, so it's rarely done now compared to before. Then brain MRI tends to come back clear without showing anything significant that could account for the symptoms that his patient comes in with. So the treatments, the first line of treatments is acetylcholinesterase. The examples are pyridostigmine and neostigmine. So we tend to use acetylcholinesterase alone in patients with ocular myasthenia gravis when it affects majorly the high muscles, causing ptosis and diplopia. But it's then used as adjuncts with immunosuppressant therapy like azatropine or cyclosporine corticosteroids in those that have generalized myasthenia gravis involving the limbs, the widespread of muscle involvement in the body. So another option is doing plasmapheresis or IV immunoglobulin infusion. This is in severe cases, relapse. There has been no improvement with using the immunosuppressant therapy or the acetylcholinesterase, then we could give IV immunoglobulins or do pharmapheresis. Then myomectomy is advised there is if there is thymoma present in patients with myasthenia gravis.